everybody, it's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways. So yeah, let's get back into this and talk about some other advanced airway things, but really mainly for special populations, right? So really we want to talk about tracheostomies and management of, and I don't know, what's everybody's experience? I feel like I have come across many pre-hospital providers that are just really unnecessarily terrified of patients with tracheostomies, and this is not beyond the realm of anybody's understanding, and it's you know, they'll pass a tube in a minute and you just shorten it a little bit and make it a little stiffer, and then suddenly it's something we're unnecessary.
More direct access to the airway.
Correct, right. It's bypassing all the upper structures, right?
Well, even the poor design of the upper airway that has the epiglottis, you've got where the airway's at, which is the airways in front of the esophagus gets tucked away so that way food doesn't go down.
Right,
you've got an epiglottis that closes on top of it. Structurally, it's there to protect the airway, but it's not a straight line. If we're trying to intubate from up top, we have issues with those anterior airways. It's hard to get up into there. That's designed so food doesn't get
absolutely
into it, but makes our life more difficult for managing an airway.
From delivering an advanced airway, a
Correct.
tube in most cases. So, I mean, I figured we'd start with at least a discussion about the tracheostomies, and then a little bit about ventilator management, not from the perspective of how to push the buttons and twirl the knobs, but just an understanding of, you know, what patients might be on them, and then what things you may need to know or troubleshoot, and if the ventilator is not working.
Not working.
But there's specific things that you need to have if you're going to take patients that were previously vented, if you're going to transition them to a BVM. It's you know.
And you have to need to use caution and stuff. We'll get into that.
We'll save that here for a second. But let's just talk about the hardware first. And in general, there's two types of tracheostomies. There's uncuffed tracheostomies that have no distal cuff here. And then we've got cuffed tracheostomies, either the exact same size and type, but one is cuffed and one is uncuffed. And you can see this has a distal cuff down here, and this works just like the cuff on our endotracheal tube, right? Conceptually, although it's much shorter because again we're accessing the airway essentially more directly and in the neck rather than top down. So we don't need all that extra length, and it's a little more rigid than your endotracheal tube.
And very often, I want to mention that those, even though it's got a cuff on it, they're not often inflated.
Yep. There is a subpopulation in there we need to talk about. So I was actually going to talk about these second. I was going to start with the uncuffed tracheostomies. So the cases where you might find somebody with a uncuffed tracheostomy are generally those patients that are spontaneously breathing, right? So this patient has some sort of upper airway problem. Probably chronic, maybe it's tongue, tracheal cancer, they've had facial trauma, they've had something that has affected the airway neck up, and we just need essentially a different blowhole. We need a different lower access into the airway, but they've got no compromise of breathing, right? So they don't have a spinal cord injury, they're breathing on their own. They just need an alternate passage for air. And that's where you'll see these patients. Now, the hole is a little lower than we were demonstrating in a previous episode with the cricothyroid membrane, although if you did a cricothyrotomy and you happen to have in your crash kit a trach, you could certainly put that in there. But they do a surgical intervention to make an ostomy further down to put a tracheostomy in. And then again, the length of this is, and we talked about this in the previous episode with the cricothyrotomy, generally pretty short, because right at the end of this, of course, here's my sternal notch. Carina is going to be right about there. So we need to, of course, have this above the level of the carina, so we ventilate both lungs. So these patients, often they've got this just sits in there, and it's usually they've got some sort of Velcro strap or some sort of a tie that goes around the back of their neck. These patients may be walkie-talkie A04, and depending on level of insult and what their what air they can get through their glottic opening. They may or may not be able to move enough air to make some sounds, or
they may have a sound block.
They might have a speaking valve on there. Yep, which allows some air to get up through the glottic opening where it may be insufficient for them to breathe daily. It's they can get enough past to verbalize some stuff and make their needs and their wants and everything known, and communicate effectively with other people. Let's contrast that with somebody who may still have upper airway insult or may have an intact upper airway, but they've had some spinal cord injury, right? They've had a transection, they're quadriparaplegic, they're not breathing on their own, they've got no diaphragmatic control. This patient's going to need to be on a ventilator, and that's where our cuff tracheostomies come in. And just like an endotracheal tube, there has to be a cuff on the end, because if you squeeze a BVM with a with a cuff down on an endotracheal tube, what happens? The air just leaks out, right? You're just gonna have a big ass leak if you don't have this cuff brought up within the patient.
There is a formula for the cuff also.
There is a formula for the cuff.
Yeah. And they do have cuffulators.
Cuffulator, yep.
That will give you I don't know if we have one.
I've got it's not a cuffulator brand, but I didn't bring it, of course. But in that same thought process, if you are picking up a patient who is on a ventilator and has a cuffed tracheostomy, one of your first stops as an assessment of the airway needs to be
squeezing
just that, is make sure that proximal cuff, that there's some air in it, which of course is telling you that this distal cuff is inflated, right? I've had a couple of calls over the years where we've gone into, say, like a nursing home, a vent unit nursing home, and they'll call us for hypoxia. You'll walk in, you'll assess the patient. Yeah, sure, sure enough, the patient's hypoxic. They look like crap. Pulse ox to match. You squeeze that and it's flat, and you put a little bit of air in it. Now, oftentimes you'll see their stats come right back up. It was a simple thing. But then 5 minutes later, stats are starting to dip again. Oh, what's going on? Don't forget, reassess this. And I've had a couple of cases where they just had some sort of, that distal cuff was torn or, damaged or otherwise leaking. Who knows why?
And then you just replace the entire unit
and then
at that
yep,
point.
It was just like, hey, respiratory, do you have another thing? And we're going to help you replace this real quick. Mm-hmm. Likewise, you walk in and somebody is on a ventilator and there is no way to inflate a cuff. That is suspicious, right? So one of two things happened. Either they've got an uncuffed tracheostomy improperly in this patient, or there was one particular patient that we were on all the time, a young girl. She was a wildcat. She would grab it and rip it off unintentionally. It's just she was just flailing. She'd get a hold of it and tear it out, right? So again, that should be an immediate clue as soon as you see somebody that's on a ventilator, on some sort of mechanical ventilation, that they should have some sort of pilot balloon to inflate that cuff. I think the point you were starting to make earlier is there's some patients, maybe walkie-talkie A04 throughout the day, walking around with a cuffed tracheostomy on, but they go on a ventilator at night, right?
Correct.
So they had severe sleep apnea. They're an OSA case, or they've got central apnea, there could be various things, right? And these patients are nocturnally vented, right? So it's almost a slam dunk. Somebody walks up to you like, "Hi, I hurt my leg," right? And then you're like, "Okay," and you've got really bad sleep apnea, and you go on the vent at night. How'd you know? Right? Well, there's your clue. It's
signs.
Yeah, signs.
There will be signs.
Yeah, there'll be signs. It's kind of dangling there in your face, like that's. And you wouldn't, if that patient was breathing substantially on their own, you wouldn't necessarily need to bring that up or do anything, bag them. If they were awake and their sympathetic nervous system was intact and they were breathing on their own and everything was good. So, is there anything else you want to say about those patients or that population?
Maybe I just see a lot of them that way. Just be leery of whether or not there's a cuff. Ask staff or the patient, hey, is this supposed to be inflated?
Yeah.
When do you inflate it? Just getting that basic information is going to help you out a lot.
Yep. then conversely, let's say that you had a patient who's normally walkie-talkie AO4, right? They're generally in good shape. They're breathing on their own. But today, or let's say over the last couple of days, they're in route respiratory failure because of ongoing pneumonia, and you're like, oh, I got to bag this patient. They're barely moving any air. Their end tidal's crap. They're hypoxic. Well, although a BVM absolutely fits on this uncuffed tracheostomy, when I squeeze this, we're going to get all kinds of leak out from the tracheostoma, right? So you got to do one of two things. So first of all, if you're in a facility that has tracheostomy patients, I think the easiest thing to do and the most overlooked thing to do, because everybody wants to do the cool thing,
give me one of these with a bag on you.
Just like, hey, here's the size of this. Do you have this size cuffed tracheostomy? Just ask, right? Can you bag them for a minute or two with, that'll buy you enough time, right? Do you have a cuffed tracheostomy at this approximate size? Let somebody go get it for you. Make everybody's lives downstream much easier, right? Yes. Conversely, they're walkie-talkie AO4, they're at home, this is all they have, right? Then subsequently, you would just pull this straight out, and then you could use, as we talked earlier, you could use a same size endotracheal tube, right?
But also, as we talked earlier, don't lose the hole. This is where a bougie comes in hand again.
You can use a bougie to replace them. But I'm also going to say is just by replacing that device, so a lot of the times it's just the device that's broken, right?
Yeah.
And that could be for a number of reasons. As we said, the cuff's down. You could have a mucus plug in there. It just could be blocked. Just by pulling it out and replacing it with a new one, you might just fix your problem.